Steve, thanks for joining me. I wanted to get just your thoughts on your career and echo and the American Society of Echo. Let's begin with, what was your first introduction to echocardiography?
My first introduction, the pivotal moment for me was as a fellow. I was in my second year of cardiology training. I had just finished 2 months in the cath lab, and I asked my supervisor, the cardiologist, for some feedback. I said, "How's it going? I'm feeling pretty good about cath, and I think my hands are okay. I'm learning a lot." He said, "Steve, we love having you in the lab. Have you thought about echo?" And until that moment, that was it. And until that moment, I had not. So I was like, "Huh, I think he's serious." So I kind of changed gears a little bit and started thinking about echo and enjoying the hemodynamics, and that was it. From then on, that was the moment that turned me to echo, and loved it.
So tell me how your career progressed. In other words, this was during your residency.
So this was core cardiology training. Okay. So then I became interested in imaging and echo at the time. And at the time, there wasn't multimodality. It wasn't CT and MRI. MRI was on a horizon, but it was, if you did imaging, it was echo. And so I pursued that. I went and did a subspecialty year of echo, knowing that I wanted to sort of be good and go deep in one area. So I went to Ottawa. I did a year of echo training, and then the center that I had done my training in called me and said, "Hey, we have a spot for you. Do you want to come back and be faculty?" I said, "That's great. I'm getting some echo training. Sign me up. When do I come back?" And they said, "Well, before you come back, we want you to go to the States for a year and go get some more training." I said, "Interesting. Okay. Where do you want me to go?" And they said, "We don't care where you go.
Just go."
They said, "Go find a spot somewhere in the United States. We want our academic faculty to have been trained in the U.S. for at least a year." So I made some phone calls and tried to figure out, where would be a good place at that era to go do echo. And I was directed to Bill Zogby. So I called Bill, Dr. Zogby at the time, and described my situation, and he said, "Come on down." So then I went to Houston for a year, did a year of training under him and some research on nascent days of 3D echo and trying to figure out 3D PISA and what it all meant, and did that, had a phenomenal year. Was back up working in Canada for 2 years, and a little disappointed with the access to innovation, the access to technology, the budgets that couldn't buy a 3D probe, those sorts of things. And by good luck, Bill Zogby called me and said, "We have a spot here now. Do you want to come back as faculty?" So I did. 2007, I went back to Houston as a Canadian who'd never done any clinical work in the U.S. system, and here I am, whatever that is, 15 years later.
10 years ago. That's a very interesting story. Like the cath lab director,
That's the importance of feedback.
I hope he's not investing stocks, because it sounds like he's not a good futurist. But so you already alluded to some of the things, but think about what are the technological developments that you've seen in your career, specifically in echo?
Well, the things that probably have influenced me the most was the commercial development of a 3DT. So when I was a fellow, we were doing research, and the 3DT was, multi-phase mechanical motors, trying to put it together, and it was fascinating but ugly and impractical. And then right around the time that I was creating a pathway of imaging, commercial development of 3D echo happened. So that absolutely transformed what I was able to do. And the early days of my research and my interest in valvular disease, it all sort of stemmed from the echo technologies that developed around the same time I did. So I would say the commercial availability of 3D echo, transthoracic and TE, just timing with the launch of my career, is what ultimately led me into interest in valve disease. And then that became the early days of interventional echo, just doing paravalvular plugs occasionally when it was possible. And then by pure luck, TAVR happened a few years later, and then MitraClip, and this whole cascade of kind of really neat activity.
So you've obviously been intimately involved in the structural world and the interventional world. I'll come to that in a minute. So that really, so the 3D echo and that launching you in that direction is an important milestone in your career, you see?
Yeah, I can't imagine the career I have now if the commercial availability of 3D echo had not happened. I would be doing different things. I don't know what those things would be.
Yeah,
but
interesting.
a large chunk of what I've sort of pursued just clinically has been based on sticking that probe in and figuring stuff out.
And you've done that very well. How did you first get involved with the American Society of Echo?
So as a fellow, cardiology fellow, finished in 2003. I don't know exactly the date that the JACE became available, but I remember getting JACE. I opened up JACE and there's echo science. So as soon as I started to think about a career in imaging and echo, it was Jack, and then none of the baby Jacks existed. It was Jack or JACE. And for, consistent echo content, I would look to JACE. So it was JACE that sort of got me thinking, and then from reading JACE, I found out more about the society, found out about the scientific sessions, got interested in writing abstracts and submitting abstracts and trying to find out who this community was. So that got even stronger, going to Methodist and meeting Bill Zogby, Mike Quinones, Sharif Naga, seeing these sort of legends in echo being all around you. So it became a really exciting place to be. So mentors, it was the journal, the society, and the luck of finding mentors.
And then you became more involved in the society, obviously, and was that through committee work or through other things? What?
Yeah, I made a conscious decision early in my career. I said, this is a group of like-minded people that I want to get to know, and I want to do more in this society. I want to learn more about this field. So I signed up for the first thing that was available, and it was I think it was an information technology committee, which I knew absolutely nothing about. I showed up at a committee, and there were some smart people in the room who knew what they were talking about, and I just kept my mouth shut because I didn't have any clue what they were talking about. And I did that for a year, and I went to the meetings, and then I eventually learned that at some point you have to risk something, say something, try to offer something intelligent, and that just sort of builds. You learn more about the society, you learn more about the structure and the function of the committee. You watch intently as the chair and co-chair manage the room, and I saw great examples of how that was done well and how that was not done not well. Right. And both were helpful. So I said, I'm not doing it that way, but I'm going to try to do it that way. And just a lot of good leadership examples came through early ASE activities. And then just kept doing that, just kept volunteering for other things. And then eventually somebody said, hey, you should be a co-chair of this thing. And then that became a chair of something. And then from there on.
What's the Echo ASE mean to you? I mean, because you've been involved and, I've come to the fact that you're the 33rd president, so it meant a lot. But as you look at it now, what does ASE mean to you?
It's a bit cliched, but it's my professional home. I have an institution I work for. I have a home with family, right. But the professional home is ASE. It's this meeting. It's seeing friends, old and new. It's mentors above and generations above, but it's contemporaries, it's young fellows and mentees. It's the place you go to really interact with. It's sonographers, it's scientists, it's now veterinarians. It's an incredible group of individuals who have a similar passion. So I couldn't imagine where I am now academically, professionally, without the ASE.
Yeah, no, it's super. So as I mentioned, you were the 33rd president. At the time of this discussion and visit we're having, you're the most recent past president. That'll pass pretty soon. Yeah. And congratulations.
Fourth Canadian.
Fourth Canadian. Congratulations on being past president. So the major sort of things that you accomplished with all the help you have, or milestones during your presidency. I did read your presidential exit piece, reflection, preparation, and gratitude. So tell me a little bit about what you think you accomplished during that period of time, or things that struck you as important.
I mean, before I started the gig, I put some time into the presidential, vision. What did I think I could accomplish, and it was important to me to try to do in 1 year, knowing you could tag a little more time in the past president year to tighten things up. But the thing that struck me after 2 years on the executive and prior years on the board is that the scope of the ASE has grown so enormously.
Right.
And, you know, the specialty interest groups, the councils, the international, the POCUS, the pediatric, it was so large that it was actually hard to understand the operations. So the inner workings, and I had a little fear that, you know, the donut would get a necrotic core. Because if you keep expanding without some internal maintenance, things don't go well. So part of my goal was to look inside and think, how well are we communicating within the society? Because that confused me. I was trying to figure things out, and it took a long time to really get a handle of. And I thought, it's taken me this long, it's going to take other people just as long. Some will be faster, but you know, it was challenging to figure out. So one of my goals was to say, how do we simplify this communication a little bit, break down these silos of committees? You know, thought about these affinity groups, trying to create like-minded or similarly tasked areas to work together. At least so that, you know, there was more synergy within the efforts of the membership. So that was, you know, partly looking in, so how do we actually help the ASE function a little smoother and make sure people know what's happening internally. And then I looked outward and I think, well, what are the things that need effort? And part of that was interventional echo, the part that's near and dear to my heart. So I knew what those challenges were, and I thought, of course, I'm going to, you know, put some energies in there. One of the things I discovered really about the ASE was the unsung value of the advocacy. You know, as a clinician, it was a term, but I didn't really understand what advocacy was or the breadth of the effort. So, you know, time on the exec, I learned a lot and became, you know, very enamored with the power and the people who are just plowing through advocacy and how important that is to our entire society. So I did want to shine a little light on that and help where possible. So I think interventional echo, a little more effort and focus on advocacy, a little internal housekeeping, I would call it, in terms of structural organization. Those are the things that I really wanted to accomplish.
Yeah, and they're all very important, and the society is better for you having worked in those directions. The affinity structure, you know, that you had that where you, tell me just a little bit more about that. The concept of that is basically different councils or different things that might have similar interest or need to communicate.
Yeah. So looking at our structure, we had, you know, 26 different committees.
Goodness.
And everyone had a chair and a co-chair, and everyone would at some point, may or may not, report up to the executive or the board, and how do those 26 committees understand who's doing what?
Right.
So there's duplication of effort, there's lack of understanding, and so the thinking was looking at those clusters and think, well, let's put some together. Let's maybe take international relations with the FASE committee, and possibly with education. I can't forget the exact clusters.
Right.
Putting a cluster together and saying, all right, let's at least have the chairs of these committees get together and have a conversation. And let's facilitate it, let's make it a Zoom call, let's allow it, make it easy for them. Mm-hmm. And then say, what are your challenges? What's working well? How is your committee running, and what are your goals? And just say that out loud to these other folks. And maybe you'll find out that, oh, we're trying to do this thing internationally. FASE is having a hard time with international. This is chocolate and peanut butter. Let's put those things together and do it together. So that was kind of the idea of the affinity group, is just say, make it easier to get more done with the same effort.
And which is going to be is valuable and going to be increasingly valuable. And I think it's really wise that you tried to look at the donut and make sure the hole didn't expand and implode or explode, whatever the current technology is. You've made tremendous advances in interventional echo. You as an interventional echo. Structural heart disease is booming, unfortunately, both in prevalence but fortunately now of a lot of technologic advances which can improve, you know, early detection and improve things. You have or are in the process of developing new guidelines or special competency in the interventional echo, and you've been, tell me a little bit about that.
So those were just published. They were out in print last month, and the fairly fast one. So that was, the field has expanded so fast, and there's lots of young people trying to get into it. Well, part of it was we did a survey a couple of years ago and said, who's doing what we would self-describe as interventional echo? And it was very bimodal. There's a group that are 10 to 20 years out, people who've learned it on the job, people like myself who've enjoyed it and try to figure it out. there's a few in the middle, and then there's a whole cluster of young within 5 years of practice who are doing it. And I think, well, we know a bunch, they're trying to learn a bunch. Let's create a list of competencies. What should somebody who claims this expertise be able to do? So let's figure out what are the knowledge competencies, the procedural competencies, the team-based expectations, the institution. What should an institution be able to offer if you're going to claim that you're training somebody in this? And what should the teachers know? So putting a hat on, you're a young fellow in either cardiac anesthesiology or cardiology, and you want to pursue this field. What should the training environment look like that you're going to? So we put that in a document. You know, it was a consensus document. It was based on a lot of trainers and a few trainees. And we listed competencies and sort of all those things. So it's sort of step one in a new field of you want to claim that you know something.
Right.
Expertise takes competency plus time.
Right.
So this is not the expertise document, but it's the competency document. The time you have to put in yourself.
It's important. I mean, it's really important because of, you know, I, like you, and because I was at the ground floor of a lot of developments of technology, but uniplane TE, and then biplane, and multiplane, and 3D, and all that stuff. And you naturally, after the OR, you migrated to the cath lab with ASD closures, PFO, LA appendage, and then now the valve stuff is exploding. And so it is important that you have that. You also did some things I thought were interesting in the artificial intelligence task force you developed or helped to develop.
Yeah, that was one of those external factors that is sort of coming at the ASE, you know, collective, whether we're ready for it or not. So a couple of things that I looked at, I said, what are we ready for? You know, within the interventional sphere, one was intracardiac echo. You know, it's coming, the technology is here, and we got to figure out how to use it, how to not use it, who's going to use it, how to train for it. So we created a task force to start give the ASE some priorities. Where should we put, you know, where should we spend our calories? Right up front. What do we need to do now? That was the goal of the ACE task force.
Right.
And similarly is AI. AI is part of every major conversation for the last 3 years. Every conference, every discussion with industry. So similarly, what does AI mean? What does it mean to our field? What does it mean to all the different stakeholders, the sonographers, the physicians, the PACS vendors, the hospitals? And so what's the terminology? What's the priority? How do we position ourselves to be, it doesn't matter whether we're for or against it, it's coming.
It's happening.
So how do we prepare for it? That was the goal of the AI task force, and they had their first report to us at the board meeting just 2 days ago, and they've, you know, under Ted Abraham, they've already done amazing things. Yeah. So there's a lot coming there, and there's a lot we all have to learn, but it's going to change our field, I think.
No, I think it's critical. It is going to happen. It is happening, and so to understand its role in echo and its role with the society is important. Put your futuristic hat on. Where are we going to be in 5 to 10 years with echo?
I would say, and part of my thinking on this is solidified at this meeting. I mean, echo is undergoing a renaissance, you know, right now. I think we've, you know, CT and CMR have been the golden child for the last few years, and echo was sort of here. But you look at our exhibit hall today, you know, 50 exhibitors. I think that's the most we've ever had at scientific sessions. The hall was enormous and packed. And who's here at an echo meeting from the industry perspective? It's, yes, we've got image vendors, and we've got PACS companies, but we've got device companies, and now we've got pharma. Pharma's here, and why is that? Because now we have therapies that require echo to identify, that require echo to moderate and monitor, and so that's an enormous opportunity for us as an echo society. We've also got a huge focus on healthcare disparities and access, which is predominantly an echo issue because that's the most sort of ubiquitous you know, tool out there to look at disease and to help people. So I think echo is absolutely in a spotlight right now for all the right reasons. And we're at a crossroads of tech, pharma, devices, political will. There's lots of reasons why echo is going to just
Point of care echo?
Point of care echo, yeah, critical care echo.
When you talk about access and things like that, it's kind of,
all of those things, and so I think you know it's a challenge for the ASE.
Oh yeah.
Because what is our our portfolio is getting a little bigger every year, and we have to manage that and think through that and create priorities. But I think your question about, the next 5 years are going to be incredibly, a lot of high energy, a little chaotic probably, but the leadership will be very important because we have to know where we're going and where we're not going with limited resources.
And have a uniformity of how to handle the developments as they do, And I mean, that's really what you're talking about. Is you better be there as being engaged in the applications and the rules and regulations involved.
You've got to be involved, but you can't chase everything because we also can't starburst. We can't chase everything at once. We have to make some tough choices about, as a society, what are we going to let happen and what are we going to lead.
Right.
So we have to make those choices.
But it sounds like you've had a good handle on starting that process. As you look back, because you've had an interesting career, both as a physician, as a clinician, as an echocardiographer, and then now as a leader, are there any noteworthy memories you have about things like events that stand out, or people, or experiences you've had that are, I'd love to hear about that.
I mean, some of my favorite memories, ASE related, are in some way linked to our scientific sessions.
Okay.
I think about the gala event last year. Sharif Naga wearing green heart-shaped glasses.
Right.
Here's the director of my echo lab at Houston Methodist, and he's having a great time, and everybody around, just the energy and the vibe was so family. So I think moments like that, and there's a dozen moments like that.
And in the field itself too, I'm sure you've had, people, you've mentioned numerous people at Houston and elsewhere that you've had experiences, with.
International collaboration. Just walking through this conference center on the way to come and chat with you, seeing old friends, international friends from different countries and different cities, and shaking hands and asking about their kids. That's these meetings. So they're absolute annual highlights, is coming here and rekindling these relationships.
Do you have can you think just quickly, rapid fire, about a case that you were involved in where echo made a major difference?
One of the cases that still strikes me was probably a year or so ago. It was a patient comes to my valve clinic and with an older lady with her son, and she had bioprosthetic aortic valve stenosis. And she came because the son had read something on our Google, on our webpage, about valve and valve TAVR.
Right. And
she had already been written off as the expression of her son, that she had severe stenotic bioprosthetic aortic valve, very elderly, high-risk surgical case. She was already off Medicare and on a form of palliative care, but somehow came to clinic. We explained what a valve and valve TAVR was. They couldn't believe that they had never heard of this from the town that they were in.
Right.
And we offered the procedure, ultimately did the procedure. She had a phenomenal outcome and flourished, but I've never had to have somebody where we reversed the palliative care, because she was and actually that was an insurance issue.
Yeah.
She had gone from Medicare to a palliative care mode, and we had to undo it simply by giving the education around a new procedure that her family, and her provider had never heard of. So just knowing that, you could have that effect on somebody and their entire family. We have dozens of stories like that, but that's sort of, you're cutting edge. You've got something that not just change a life, but prolong a life and change the life of everybody around them.
And give her a quality of life as she...
Total quality of life. She's still doing fine. She comes back and sees me every year, and we have a little joke about how challenging her insurance change was.
But anyhow, listen, you've been an outstanding shining light in our field. You've made tremendous advances and helped us all learn with innovation and structural heart and other things, and then as president of the ASE. So thanks very much for joining us.
Thank you, Randy. Appreciate being here.